Very good morning, ladies and gentlemen. I would like to welcome all of you for yet another weekly Sunday CPD webinar series organized by the Society for Health Research and Innovation, as well as in collaboration with Sri Lanka College of Internal Medicine. So we have a very interesting topic today. Just before going into that lecture, I would want to remind all of you about our housekeeping mannerisms. As you all know, our webinar link will be available only up to 9:45 a.m. today to join in, and no late attendees will be entertained after 9:45 a.m. After that, we advise and we request all the attendees to switch off your microphones, mute your microphones, and do not share your video also. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD point, as the CPD points are strictly adhered to the NCCPD guideline. This is only to improve and maintain the standard of the CPD program conducted by Sri in collaboration of the Sri Lanka College of Internal Medicine. As well as I would want to remind all of you, if there is unfortunate event that you logged off from us, you can call a number that we are going to post in the chat box in due time, and you can join with us again to continue with the program. All your questions, please do send us through a chat message, and they will be answered by the today's lecturer. So let's move on because we are already running late to today's lecturer, Dr. B.V.S. Ruanpriya, one of the greatest products from the University of Colombo, who has finished his MD in psychiatry from the PGIM. After that, has gone to Australia for his foreign training, and now serving our country from year 2000 onwards. So to deal us with this very much time-sensitive topic, I would cordially invite our distinguished speaker to continue with this CPD program. Thank you very much, and over to you, sir.
Thank you, Sahan. So I will start. So I will share the presentation now. So you can see the screen now, right? Okay. So let's start. So during next 45 minutes or so, I am going to discuss basic things, whatever you need to know in managing agitated patient in a primary care setting. So I am not going to talk about hi-fi stuff like how to manage a patient care, agitated patient in a psychiatric setup, or I'm not going to tell. This is for the doctors who are working in primary care, maybe emergency departments, medical wards, right? Okay. So first, what we need to know when we are managing a disturbed patient. So in this lecture, we will talk about what are the things that we need to know, and also the main thing is our own safety and safety of others, right? So we are discussing how to deal with that, and then dealing with disturbed patients, what are the differential diagnosis and what to do, right? And then about post-incident relief, right? Okay. So suppose that you are working in a peripheral hospital, maybe a divisional hospital or base hospital, right? And a patient presenting to you with agitated or disturbed behaviors, right? So another doctor will be working in a tertiary care hospital, maybe a teaching hospital or somewhere in an emergency department, right? So like that, the setting will be different, right? And resources available in the setting also will be different place to place. So always you have to consider where are you working and what are the resources available before dealing with these patients, right? Whenever or wherever, our main goal is to calm down the patient, right? Our main aim is to reduce the harm, right? Reduce the harm means reduce the harm to the patient, reduce the harm to the others and the staff members, as well as for the properties, right? Right. So in the immediate management, we need to assess the immediate risk to the patients and others, as well as for the property, right? And then we need to exclude life-threatening conditions, right? We will discuss what are the life-threatening conditions, right? And then the rapid tranquilization. And later on, we can go for the detailed assessment. What are the causes for this disturbed behavior? And then what is the specific management, right? Okay. So in the assessment of the patient, we need to assess the immediate risk of harm. That is the main aim of managing these patients, right? If patient is very, very restless, we can't take the history from the patient. We can observe, right? Then what we can do is we can take the history from a accompanying person, right? Sometimes the police will bring patients with aggressive or agitated behavior. So even you can take the history from the police members, what they have observed and what are the main aggressive behavior they observed. Like, was it verbal aggression? Was it like physical aggression? Was it throwing things at others like that? Right? Okay. And then with the history you can get some clues whether this patient has had a previous history of mental illness, or whether this is the first presentation, whether this patient can tell his name, age, and those things like that, right? And then if you can take further details, the previous history of aggression, right? Access to weapons, intoxication with alcohol or substances. Those things are very, very important because these things can predict um, the severity of aggressive behavior, right? Suppose that patient has history of previous aggression, then there's always high risk of repeating the aggression again, right? And we don't know, sometimes patient will keeping some weapons like maybe knives, maybe scissors, and sometimes even if this patient is working in a forces or somewhere, they can sometimes present it guns, right? Um, so always you need to think before getting into any trouble, right? And also you can see whether this patient has been intoxicated with alcohol or any other substances as well, right? If these things are there, then risk of aggression is very high, right? And also you need to consider about head injury and recent worsening of medical conditions, right? Because sometimes head injury or like medical conditions such as medical conditions causing delirium, right, can also present with aggressive behavior, and sometimes these patients can also become very aggressive, right? Right. And if you think that this patient is having a mental illness, right, then delusions and hallucinations also predict the risk of aggressive behavior, because sometimes persecuted delusions means patient believes that there's somebody or someone to harm him, right? Some people are trying to harm him, trying to kill him, right? So some patients with mental illness, they believe this, right? So we call it persecutory or paranoid delusions. So such patients are also are at high risk of becoming aggressive behavior towards others, right? Because they are trying to, in their point of view, they are trying to prevent uh, get harm from others, so they try to become physically aggressive, right? And sometimes hallucinations are the perceptions you get, right? So some patients get auditory hallucinations, like commanding hallucinations, they get these commanding voices to maybe assault others or maybe to kill others, right? So they hear these voices, you go and kill that person, right? Like that. So then some patients who are having substance intoxications or mental illness or delirium can respond to these commanding hallucinations, right? And these people also can become very aggressive at times, right? Okay, so you have to consider when you assess the patient, you have to keep these things in your mind, right? Okay, right. Then what you can do is suppose that now um, you have done a basic assessment, right? And you have excluded these things, and now you know that patient does not carry any weapons, and you are safe to some extent, right? And then you can introduce yourself, right. Even patient present with very aggressive behavior, usually to a medical person, you know, the doctors and nurses, they usually in our setup, they do not get become aggressive, because most these our patients will respond to authority of a medical person, right? um, we know that sometimes some patients are very aggressive towards police, but when they come to hospital, uh, they will respond to our commands and requests, right? So you can use that. You have to show that, right? You have to show that you are confident, because if you show that you are not confident and you are anxious, then some patients can become more aggressive. Some patients will not respond to your authority. You need to go to patient and talk. So my advice is not to go too close. Just you can maintain some distance and talk directly, saying that I am so and so. I am Doctor Silva, and I am the in charge medical officer here, right? Like that, and you can uh, ask himself or the patient to calm down. You can say that I am here to help you, right? I am here to listen to your problems. So don't become aggressive. Just sit down and calm, right? If you tell this in a firm manner, right? Uh, in a confident manner, then most of the patient, 90% of time, the patient will sit down and listen to you, right? Okay. But don't become aggressive, right? If patients, sometimes patients become aggressive, and sometimes when they come and they will start talking inappropriate manner, right? Because sometimes if there's a lady doctor, sometimes some patients can come and um, um, ask, come and tell that you are beautiful, or are you married, or some kind of offending things the patient can talk, right? So, uh, so don't get offended and don't become angry, because if you become angry, then you will also talk in an aggressive manner, right? Irritable manner. So always keep in mind that this is a patient, and this patient is in a helpless condition. So we need to help them, right? So don't get these things into a personal way. Just um, you can go and talk to the patient. You can tell, I am not going to talk about these things. I am here to help you as a doctor. So let's talk about your problems. So let's talk what are the problems you are having, like that, right? Okay. And sometimes they will try to make arguments with us, right? Sometimes they will come and say that what kind of doctor you are you a qualified person, or you are not, I can't see you as a doctor because you are too small, or you are too young. You shouldn't be a doctor. You are kind of a student, like that. Some patients can come and tell these things, right? So you don't have to get into these arguments or give lengthy explanations, right? And also, if patients tell that what you are going to do with me, you can tell that I am here to help you. I am here to give some medications. I am here to get some blood investigations, and I am here to um, help you for your pains or your problems or whatever, right? But you don't need to explain in a lengthy manner, right? Because if you try to explain, because we don't have a lot of time, as well as sometimes these lengthy explanations can cause more agitation and irritability in some patients, right? So you need to be very clear in very short manner, just a few sentences, and then you are done, right? Okay. And always remember not to get into enclosed areas. Sometimes we see patients in rooms, right? Sometimes there are some enclosed areas in our clinic rooms, maybe in emergency department. Always be in open space, right? So you can, it is for your safety because you can escape, right? And always if patient if aggressive, if somebody brings aggressive patients to your room, don't sit in the other side of the door, right? You always try to get up, and then you stay close to the door and always try to keep the door open, right? Because sometimes if you in the other side, sometimes if patient become very aggressive and try to hit you, then you don't have enough space to escape, right? So you need to keep these things in your mind, right? And the best predictor of aggression is past and present aggressive behavior, right? So whenever you are taking the history, you can ask whether this patient was aggressive in the road, whether this patient was aggressive in the hospital, in the home, like that, right? If patient was aggressive there, then there's a high risk of repeating aggression again, right? Um, and also past history of conviction or arrest or some legal problems, right? Also indicate the high risk, right? If patient possesses any weapons or anything can use as a weapon, you need to remove these things immediately. So in our setup, what we can do is we always can call the police, hospital police or security staff, and tell them that there's a patient with aggressive behavior, so we need your help. So please send many officers as you can, right? So sometimes they will send one security officer who is not very confident. So then you are again helpless, so right. So you can get some attendance, some if you have a police force, you can get one or two police officers from the police force, and also some security officers. Tell them that this is only for very this is only for like 5 to 10 minutes thing. So please come, right? So when they come, you have help around, right? Then you can remove these things, any weapons or these things, with the support of them, right? Right. Um, okay. So don't forget to call the help, right? Because sometimes we feel confident and we go we try to manage this patient ourselves, because it can cause significant risk at times to ourselves, right? Suppose that if patient is having mania, psychiatric illness, or if patient is having delirium, right? If patient present with head injury and the patient, right? Then we have to suffer ourselves, no? So always uh, think that safety of us, safety of our staff members, and then the equipments around us, the safety of his equipments, those are the first priority. And then is the managing patient. It doesn't mean that you need to pass the ball to somebody else, right? Because when a person present to you, you have to do something. You have to do the main basic things, and at least until the patient is transferred to somewhere, you have to stabilize the patient, no? Right? So it doesn't mean that you need to just put the patient in an ambulance and send the patient to some other hospital, right? But uh, my 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 message is safety of us is the first priority, right? Because I don't see this in our hospital setup sometimes, because when we are working in Australia, we see this, because these the staff members, they always communicate that to other staff members as well. The safety of us is a first priority, right? So we should do in our setup as well, right? Because we know sometimes uh, very, very rarely patients get aggressive and irritable. Sometimes it can cause significant harm to our staff members. So then we don't get anything. We don't get any compensations or anything. We just have to suffer ourselves, right? So keep that thing in the mind. Get the help, and then only um, uh, approach the patient, right? Even sometimes if you don't have enough staff members, maybe in small hospital we don't have police post, we don't have security officers, then always you can get the help of family members, right? So most of the time these patients will be brought by the family members. So you can ask their help as well, right? That is all right, right? And then when you did the basic assessment, um, we have to decide whether there's an immediate high risk or whether there's where immediate risk is low, right? If immediate risk is high, probably the patient might need admission, right? And then the de-escalation, tranquilization, sometimes rarely patient will need restraint or seclusion, right? And then we can do a detailed assessment and specific management. If the immediate risk is low, right? If patient is brought to the hospital by somebody telling that this patient is very aggressive at home, but when patient presented to the hospital, the patient was not very aggressive. You can see that, right? Right. So then you can do the detailed assessment and identify the cause, right? And then decide whether the patient needs admission, right? What is involuntary admission? So sometimes if patient present to hospital, if they are very aggressive or irritable, uh, they cannot give the consent. You know that, right? So they will refuse the admission. They will come and say that I don't want to come to the hospital. I don't need admission or anything like that, right? So so you can understand whether this patient have the capacity to give the consent or the patient consent is unstable. So then the involuntary admission can be done. So usually it should be done under Mental Health Act, but because at this time we don't have a comprehensive Mental Health Act to in the to uh, which is valid all over the Sri Lanka. As doctors, we can use some points in this Mental Health Act to uh, uh, help these patients or manage these patients, right? So we will discuss what are those things that we can do, right? And for the patients who are acutely ill, most of the time they require the immediate treatment and then subsequent admission, right? So involuntary treatment is necessary for the safety when patient is unable to give the consent or refuse admission, right? So so whenever needed, you can go for involuntary treatment because always we are going for involuntary treatment in most of the setup. We don't ask patient, no, are you willing to get admitted or not? No, we take our decision and we admit the patients. No, but in if we consider medical ethics and other things, we need patients' consent. No, but most of these patients who are presenting irritability or aggressive behavior, they don't have capacity to give the consent. So you can go for involuntary assessment and involuntary admissions, right? Okay. And restraining. So some of you might have experienced restraining, right? Some of you have done this thing in your setup, right? Restraining is an acceptable method of managing a very restless patient. You can use that because it will reduce immediate risk to patients and also others, right? And also restraining will allow assessment and administration of medication because sometimes patient will not allow you to give the medication. So the patient need to be restrained sometimes, right? And for the restraining, you need adequate number of staff members, right? You can't go and restrain the patient yourself, no. So at least you need at least 6, 7 staff members, right? We usually consider like one patient, one staff member for each, like two staff members for the upper limbs, and then two for the lower limbs, right? And then one for the head, and one for at least five need to be there. And then another should be there to administer the injections or other medications, right? Okay. So without adequate staff members, don't try to restrain the very aggressive patient, because then they can become physically aggressive towards you, because when you try to restrain a patient will be very threatened and very anxious, right? They will think that we are going to harm them. So they will also get offended and they will become aggressive, right? Okay. And also remember that this restraining should be only done for a very short period, right? Um, because we don't recommend patient restraining for like hours and hours, right? Because it is against the medical ethics and the humanistic approach of treatment. Okay. And ideally, patient need to be strapped to a bed, which is made that for that purpose, right? We should not use wires or ropes. We have seen that in some instances, um, patient is restrained using wires and ropes. So it will cause significant harm to the patient, significant damage to tendons, significant damage to blood vessels, right? Sometimes these damage can be permanent, right, in some patients, right? So so please don't use wires or ropes, right? When we restrain a patient, uh, we need to review the patient in every 15 minutes interval, right? We don't just restrain the patient and just just forget it, right? And what we observe is level of consciousness, pulse, breathing, circulation of the limbs, right? Okay. And then when the patient is sedated, or when the patient is calm, we can remove the restraint, because uh, uh, prolonged restraint is not recommended, right? So this is the ideal way of restraining a patient, you see, right? So there's a strap around the chest and one in the thigh area, and then there are straps for limbs and arms, right? Okay. So the patient's head need to be uh, keep in a straight posture, and patient should allow to move his neck and those things, because otherwise it can cause significant injury to the neck, right? Okay. Because we don't have this kind of straps or this kind of special techniques in our setup, what our staff members are doing is they use these bed sheets or blankets, and then they use as these straps, right? That is all right if these uh, bed sheets are used in a appropriate manner, right? You can flap and make as a wide strap, right? Because thin straps can cause significant injury to uh, body, right? Okay, right. Okay, but don't allow your staff members to use. Sometimes they use gauze bandage, no, right, to restrain arms and legs. So this gauze bandage can cause some tendon injuries and some injuries to vessels. So always do not encourage these things, right? This is the unsafe way of restraining, you see. In this manner, sometimes their shoulders can be damaged, their nerves can be damaged, right? Okay. Patient can become more irritable and aggressive because they are in pain, right? Right. And and then one patient is settled, calm, you need to see whether this patient is having features of head injury or hypoglycemia. Suppose that now patient is restrained and now the nursing staff can take right. So you need to assess whether the patient is having head injury, hypoglycemia, and then patient's respiratory conditions, right? Okay. And then always you should do this before the tranquilization, right? Because tranquilization uh, is the medical way of calming down the patient, right? So we will talk about that later. Because when you tranquilize the patient, you will mask some features, some symptoms of head injury, hypoglycemia, or cardiac or respiratory problems. So please try to assess these things before you tranquilize the patient. Don't give IM injection just um, soon as patient presenting to you, right? And then when patient is sedated, you can't assess anything, right? Okay. And okay, the physical examination and necessary blood investigation should be done to exclude the causes. Right. So we'll discuss what are the other things we can do now, right? So monitoring. So we will discuss what are these are the medications that we can use, right? Um, Now the patient is at least you have assessed the basic things you know that patient is not in a very serious life-threatening condition, right? Then you can offer some medications, right? Always talk to the patient and say that, okay, I will give you some medications. These medication will help you to calm down because you are not in a very good state to talk about your problems, right? If patient is willing to take medications, then you can use these combinations, right? So one thing is olanzapine plus benzodiazepine plus promethazine. Promethazine, right? Promethazine is what this okay, right. So olanzapine you can go for 5 to 10 milligram. Usually we have 5 milligrams and 10 milligrams tablets in hospital. In even in small hospitals we have olanzapine, right? Olanzapine is a rapidly acting benzodiazepine, so you can use lorazepam 1 to 2 milligram. Or if you don't have lorazepam, you can use clonazepam or diazepam or whatever the benzodiazepines you have in your facility, right? So if you are using clonazepam, it should be like 1 to 2 milligrams, right? If you are using diazepam, it is maybe you can just go for a bit higher dose, right? And then combine it with promethazine, right? Because promethazine has a sedative effect, so adding promethazine will help the patient to sleep. Okay, so right. Then the other option is oral haloperidol plus promethazine plus a benzodiazepine, right? If you don't have olanzapine, then you can use haloperidol. Olanzapine is better compared to haloperidol because olanzapine does not cause extrapyramidal side effects, right? What are the extrapyramidal side effects? Acute dystonia, this Parkinsonism features, then akathisia, those things, right? So because olanzapine compared to haloperidol, olanzapine does not cause those problems. You can always go for olanzapine as a first choice. If you don't have olanzapine, then use haloperidol. Haloperidol also 5 to 10 milligrams. Usually in small hospitals, we have haloperidol 1.5 milligram tablets, right? So you can use like 9 milligrams. You have to use 6 tablets, right? 6 tablets with maybe clonazepam again plus promethazine 25 to 50 milligram oral, right? Okay, so then you give oral and then wait for some time, right? And then see whether patient is calmed down, right? If patient refuses oral medication and if think that this patient is too aggressive to give oral medications, then you can go for IM injections, right? IM haloperidol 5 to 10 milligram uh, combined with IM midazolam 5 milligram and IM promethazine 25 to 50 milligram is a better combination that you can use, right? Usually we have IM haloperidol, the vial is 5 milligram vial, so you can use that. And we have IM midazolam as well in the most of hospitals and IM promethazine as well, right? So you can use these. Combination of haloperidol plus promethazine is better and safer compared to the IM haloperidol plus IM midazolam, because whenever we give IM midazolam, it can cause respiratory depression, especially in patients with some respiratory problems, right? So if you have any doubts, right, if you don't have enough facilities to monitor the patient, you can use haloperidol plus promethazine, right? It is a safer combination, right? Okay, because haloperidol will reduce the agitation while promethazine will sedate the patient, right? Okay, right, because promethazine is usually a sedative medication and it does not uh, cause any significant life-threatening side effects like other medications. So you can use promethazine, right? Right. So what we should do after IM medication, right? Uh, because IM medication always carries a risk of uh, life-threatening condition. One is IM haloperidol can cause QT prolongation and cardiac arrhythmias, right? IM midazolam can cause respiratory depression, right? So we need to monitor the patient in every 10 to 15 minutes intervals in the first hour, right? You need to instruct this very clearly to your nursing officers that you need to monitor, right? And then every half hourly till the patient is ambulated. In the first hour, 10 to 15 minutes interval, and then half hourly till the patient is ambulatory. What is ambulatory? Patient can talk, patient can maybe walk, or patient is moving the limbs, right? Okay. The further monitoring of following level of the sedation, temperature, right? Whether patient is having any features of dystonia, the pulse, blood pressure, respiratory rate, these things also need to be monitored, right? Right, right. If you so you give the IM medication, but patient is still aggressive. What you can do, you can repeat IM medication again in 10 to 20 minutes after the first dose, right? If no response, right? So suppose that you have already given IM haloperidol 5 milligram and IM midazolam 5 milligram. So you can again use the same dose after 20 to 30 minutes, right? So maximum dose of haloperidol for 24 hours is 20 milligrams, and maximum dose of midazolam for 24 hours is 30 milligrams, right? So promethazine, usually you can go for like 100 or 150 because it does not cause significant problems apart from prolonged sedation, right? So that is why I have not mentioned about promethazine here, right? Promethazine is safer, so you can go for like maybe you can repeat 25 milligram 4 times a day or 50 milligrams 3 times a day, like that, right? Okay. So oral medications also, they have the maximum dose. Olanzapine, it is up to 30 milligrams. Clonazepam, it is up to 6 to 8 milligrams. Clonazepam, you can go for 12 milligrams per day. Haloperidol also, it is the oral dose and IM dose is same. IM dose is 20 milligram, while oral dose is also 20 milligram for 24 hours, right? So suppose that in very, very rare instances, sometimes patient will not respond to repeated IM maximum doses. Then what we can do? The next option is to sedation with anesthetic agents and ventilate the patient under the guidance of a anesthetics, right? Because our aim is to assess the patient and what is the problem with the patient. Because if patient is repeatedly aggressive or irritable, we can't continue our treatment. We can't go for a CT scan in the brain. We can do any other assessment. So if patient is not responded, then this is the option. But in primary care setup, like in divisional hospitals, we don't have this facility, right? Then you might need to transfer this patient to the next facility where these facilities are available, right? Okay. So with regard to medication, I repeat this again because this is a very, very important. always go for oral medications whenever possible, right? Because it will reduce the risk to patient, as well as from your professional point of view. You don't have to monitor the patient very frequently as compared to the patient is on oral IM medication, right? Okay. IM medication always carries additional risk, right? But it doesn't mean that you should not give, right? So do not hesitate to give IM medication whenever necessary, right? So what I need to tell is, sometimes I have seen some patients were given IM medication straight away without asking whether this patient is whether patient can take oral medication or not. Whenever patient present with aggression, then we are trying to give IM medication, so, right? So please don't do that. Offer the oral medication first, and then if patient refuses, then go for IM medication, right? And when patient is restrained, please remove the restraint when the patient is sedated, because will persistent restraining will damage the patient, right? Okay. So in our psychiatric units, we have this facility called seclusion, right? Because some of these patients will become more aggressive when they are in stimulated areas, like when they are in crowd, when there are people around, when there are loud noises around, they will become more irritable and aggressive. So in mental health setup, in psychiatric unit, we have these special rooms called seclusions. So this is a picture of seclusion. So we can keep the patient in the seclusion for some time until patient is calmed down, right? This is also uh, can be done under the Mental Health Act. This restraining, IM medication, oral medication, seclusions, these are um, uh, uh, the treatment methods that we can use in under the Mental Health Act, right? So you don't have seclusion rooms in your setup, but you can do the other things, right? Okay. Right. So then when the patient is settled, we can see what are the causes for this agitated or aggressive behavior. So there are psychiatric illness, as you know, paranoid schizophrenia, manic episode, personality disorders, right? Sometimes these borderline and antisocial personality disorders can present with aggressive behavior and dementia, right? And always think about substance intoxication, right? Because we know that now methamphetamine, ice, is very common in our setup now. So methamphetamine intoxication can present with very severe, significant aggressive behavior. And cocaine, right? Especially in this Western province, cocaine is available, right? Then stimulants, right? Cannabis intoxication, right? Sometimes some over-the-counter medications like pregabalin, tramadol, these things also can present with aggressive behaviors, right? Okay. And then delirium, right? Don't forget about delirium, especially when patient is elderly, right? If patient is having a medical condition such as diabetes, chronic kidney disease, right? Cancer, right? Um, these patients can even a body, they can present with aggressive behavior because they are delirious, right? And then the head injury, hypoxia, right? Sometimes acute stress reaction, right, can also present with aggressive behavior. What is acute stress reaction? Sometimes a patient who are perfectly normal will be brought to you saying that after the death of this patient become very aggressive, like that. So acute stress reaction. Sometimes some very stressful condition at home or somewhere, some patients tend to become very aggressive as a response to that stress, right? So it can also uh, present as one cause, right? Okay. Any acute medical condition in elderly also can present in aggressive behavior, right? So don't miss it, right? when patient is sedated or settled, always look for other causes, even in a patient with past history of mental illness, because we always think that mental illness is the only reason to become aggressive behavior, right? Okay. So mental illness does not present always with aggressive behavior. Rarely, right? Very rarely it can cause it aggressive behavior. So there are a lot of other causes to aggressive behavior rather than mental illness, right? If history of mental illness or other features suggestive of mental illness, then you can always seek further psychiatric opinion from your medical officer who are in charge in the psychiatric services, or the consultant or somebody, right? Okay. Commonly, mania with psychotic symptoms, schizophrenia, learning disability, post-ictal state following seizures, agitated depression, right? And dementia, those things are the common psychiatric illnesses which will present with agitated behaviors, right? So these are the take-home messages. Always look for other causes apart from mental illness. Safety of yourself and other staff is your priority and your responsibility. So always think about that. Always get help before dealing with agitated patients, right? Always try to offer oral medication first, right? And then allow patient to calm down in a less stimulating places, right? Less crowded places, right? Right? And then if patient is not settled, then you can go for IM medication, right? And when you give IM medication, always instruct your nursing officers to closely monitor the patient to avoid the subsequent life-threatening conditions, right? Okay. So that is all that I have to tell. So now it is time for questions and any clarifications. And those MCQs, I know there's some miscommunication because those MCQs were not single based answers. It is true and false answers, right? So you will find in those MCQs there are some true responses and false responses, right? It is multiple choice, right? Okay. So there are 4 MCQs. You might now know all the answers, right? Okay. If any questions you have, you can ask now.
Yes, sir, there are some questions already posted, and because we are running out of time, sir, we plan to send those questions to you in email, and we will
Yeah.
answer in due time, sir. So thank
Okay.
you very much for that excellent and very innovative and timely sensitive lecture that you have given us today. So we thank once again to Dr. B.V.S. Ruan Priya, a consultant psychiatric from the District General Hospital, Ampara, for giving us your valuable and very important, precious wisdom and sharing it with all of us. I would like to thank all of the participants also for participating today for this Sunday weekly CPD webinar series. And we do hope that you will join with us in the future also. So this webinar series is organized by the Society for Health Research and Innovation, as well as Sri Lanka College of Internal Medicine in collaboration. So thank you very much, everyone, once again. And the link to submit and get your CPD certificate is available at the moment on the chat box. So you can go through with that procedure and claim your CPD certificate also. Thank you very much once again for joining with us, for all the participants, and a very special thanks go to Dr. B.V.S. Ruan Priya for giving us your valuable time and sharing your knowledge with us. Thank you very much, sir, and have a very pleasant day. Thank you.
Thank you, San, and all of the doctors who joined. Thank you very